Today I will be talking about local anesthesia and conscious sedation. The contents are introduction, historical background, definition, methods of inducing local anesthesia, desirable properties, electrophysiology of nerve conduction, impulse propagation and spread, theories of mechanism of action of local anesthesia, dissociation of local anesthesia, mode and site of action of local anesthesia, the classification according to biological site and mode of action, injection technique, local and systemic complications, special care group, recent advances, conclusion and references. Historical background. Cocaine is the first local anesthetic agent which is isolated by Niemann in 1860 from the leaves of coca tree. Its anesthetic action was demonstrated by Carl Kohler in 1884. First effective and widely used synthetic local anesthetic is procaine, which is produced by Enhorn in 1905 from benzoic acid and diethyl ethanol. Its anesthetic properties were identified by Bieberfeld, and the agent was introduced in the clinical practice by Braun. Lignocaine, which was discovered by Neil Lofgren in 1948, the discovery of its anesthetic properties was followed in 1949 by its clinical use by T. Gold. Definition: local anesthesia is defined as a loss of sensation in a circumscribed area of the body caused by depression of excitation in nerve endings or an inhibition of the conduction process in peripheral nerves without loss of consciousness. So the important feature is it induces loss of sensation without inducing loss of consciousness. Theories of mechanism of action of local anesthesia: acetylcholine theory, calcium displacement theory, surface charge or repulsion theory, membrane expansion theory, and specific receptor theory. Acetylcholine theory. Acetylcholine is a neurotransmitter at the nerve synapses which is supposed to be involved in the nerve conduction. In calcium displacement theory, depolarization is prevented by displacement of calcium from certain membrane sites that control the permeability to sodium. Surface charge or repulsion theory. Local anesthetic agents, they bind to nerve membrane and change the electrical potential at the membrane surface. So local anesthetic molecule with net positive charge, they make the surface potential at the nerve membrane more positive and reduce the excitability of nerve by increasing threshold potential. Membrane expansion theory. Local anesthetic agents diffuse to hydrophobic regions of excitable membrane and expand the membrane, preventing sodium permeability. Specific receptor theory. This is the most accepted theory. Local anesthesia act by binding to specific receptors on sodium channels in the nerve membrane. Once the receptor access is gained by either on its external surface or on the internal exoplasmic surface, sodium ion permeability is decreased or eliminated, interrupting the nerve conduction. This is the process of action potential. The impulse are getting transmitted. These are the dendrites, and this is how impulse get transmitted. More sodium ions which are present outside the cell membrane. So because of this, the resting membrane potential is minus 70 millivolt and the net charge is more positive outside as compared to inside. This is the sodium potassium pump through which the sodium and potassium ion they get exchanged. In exchange of 3 sodium ions, 2 potassium ion exchange from inside to outside, and sodium ions they move from outside to inside. This is known as axon hillock or trigger zone. Positive charge, it becomes more inside of the cell because sodium ions they have moved inside. So minus 70 millivolt is the resting membrane potential. Minus 55 millivolt is the threshold potential. This is the rising phase or depolarization. When sodium ions, they move through the sodium channel from outside to inside. This is the falling phase when potassium channel opens, through which the potassium ions they move to outside from inside, and there will be hyperpolarization. So this is the process of action potential. Lignocaine, it diffuses through the cell membrane. It binds voltage-gated sodium channel. It blocks the sodium entry into the cell, raises the threshold for excitation. So there will no generation and conduction of action potential, and local anesthesia is achieved. Classification of local anesthetic agents on the basis of source of occurrence: naturally occurring, example cocaine; synthetic compounds, nitrogenous and non-nitrogenous. In nitrogenous compound, we have derivatives of PABA, that is para-aminobenzoic acid. Example procaine, which are freely soluble; benzocaine, purely soluble. Derivatives of acetinolide, example lignocaine or xylophone. Derivatives of quinoline, example cincocaine. Derivatives of acridine, example bupricane. Non-nitrogenous compound, example benzyl alcohol. Drugs with local anesthetic action, example clove oil, phenol, certain antihistamines such as diphenhydramine. On the basis of chemical structure, they are classified as esters and amides. Esters of benzoic acid, example cocaine, benzocaine and butane. Esters of PABA, example procaine and chlorprocaine. The ester drugs are less stable in solution and they cannot be stored as long as amides. The metabolism of most esters result in production of PABA, which is associated with allergic reaction. Amides, example articane, bupivacaine, lignocaine, mepivacaine. Amides, these are heat stable and they rarely cause allergic reaction. So now they are most commonly used. Quinoline group, the example is senbupridine. On the basis of duration of action, short acting, examples are articane, lignocaine, mepivacaine. Long acting, bupivacaine, bupricane. Ultra short acting agent, the duration of action which is less than 30 minutes. Example procaine without vasoconstrictor. 2% lignocaine without vasoconstrictor. Short acting agent, the duration of action is 45 to 75 minutes. Example is 2% lignocaine with 1:1 lakh concentration of epinephrine. 4% prilocaine when used for nerve block. Medium acting agent, the duration of action is 90 to 150 minutes. Example 2% lignocaine and 2% mepivacaine with a vasoconstrictor. Long acting agent, the duration of action is 180 minutes or longer. 0.5% of bupivacaine with 1:2 lakh concentration of epinephrine. Properties of an ideal local anesthetic agent: it should not be irritating to tissue to which it is applied. It should not cause any permanent alteration of nerve structure. Its systemic toxicity should be low. Time of onset of anesthesia should be short. It should be effective regardless of whether it is injected into the tissue or applied locally to mucous membrane. The duration of action should be long enough to permit the completion of procedure. It should have the potency sufficient to give complete anesthesia without the use of harmful concentration solution. It should be free from producing allergic reaction. It should be free in solution and relatively undergo biotransformation in the body. It should be either sterile or be capable of being sterilized by heat without deterioration. Coming to the chemistry, it is an amide and acetinolide derivative. It is a white crystalline powder with a melting point of 69 degrees Celsius and used as a hydrochloride salt. pH of plain solution is 5 to 5.5, while that of the solution containing vasoconstrictor is 3 to 3.5. Pharmacology: diffusion. It rapidly diffuses through interstitial tissue into lipid-rich nerve, giving rapid onset of anesthesia. The dissociation constant is 7.85. It favors deprotonation and produces more available free base for action on the nerve membrane and for conduction of nerve block. Pharmacokinetics of the local anesthetic. Lignocaine undergoes biotransformation in liver. It is metabolized in liver by microsomal fixed functional oxidases. They are not affected by enzyme plasma cholinesterases. Hence, these are the agents of choice in patients with abnormal or insufficient amount of this enzyme. Cocaine is the only local anesthetic that produces vasoconstriction. Initially, it produces vasodilation, which is prolonged by vasoconstriction. Coming to the route of administration, except cocaine, local anesthetic, they are poorly absorbed from GIT. Tokenamide hydrochloride, an analog of lignocaine, which is effective orally. Topical route, local anesthetic, they are absorbed at different rates after application to mucous membrane. In the tracheal mucosa, uptake is as rapid as with intravenous administration. They are used 2% in the form of jelly, 5% in the form of ointment, 10% and 15% in the form of spray. In pharyngeal mucosa, uptake is slow. In bladder mucosa, uptake is even slower. EMLA, that is eutectic mixture of local anesthesia. It is a cream composed of equal amount of lignocaine and prelocaine, that is 2.5%, and it is an emulsion in which the oil phase is eutectic mixture of lignocaine prelocaine in a ratio of 1:1 by weight. It provides surface anesthesia for intact skin because intact skin is a barrier to drug diffusion. EMLA must be applied 1 hour before the procedure. If it is mucosa, then it should be applied 10 to 15 minutes prior to the surgery. Maximum recommended dose. Lignocaine is used in the concentration of 2%. It means 2 gram of solute is contained in 100 ml of solution. This means 2000 milligram of solute in 100 ml of solution. Hence, it means 20 milligram of solute is contained in 1 ml of solution. In other words, 1 ml of 2% lignocaine contains 20 milligram of lignocaine. Local anesthetic agent with vasoconstrictor. As per manufacturer, the recommended dose of lignocaine with vasoconstrictor, such as epinephrine, is 7 milligram per kg body weight, but not to exceed 500 milligram. In India, standard cartridge contains 2 ml of LA. Hence, the recommended maximum dose of the agent will be contained 25 ml, that is 12.5 cartridge of LA solution. Local anesthetic agents without vasoconstrictor. As per manufacturer, the recommended dose of lignocaine without vasoconstrictor is 4.4 mg per kg body weight, but should not exceed 300 mg. A lesser dose recommended because of faster absorption of local anesthetic agents. The dose is 15 ml or a maximum 7.5 cartridges of LA solution. The maximum recommended dose for various body weights, and these are the cartridges. Various local anesthetic agents along with their concentration and contents. Dental cartridges 2% lignocaine with epinephrine 1:80,000 concentration, which is most commonly used in India. Vials are available 2% lignocaine without epinephrine and 2% lignocaine with epinephrine in the concentration of 1:80,000, 1:1 lakh, and 1:2 lakh. Toxicity of lignocaine on central nervous system. It first produces stimulation followed by depression, and the manifestation they vary from mild restlessness to severe convulsion. Lignocaine administered intravenously is capable of producing a degree of analgesia and even general anesthesia. On cardiovascular system, decrease in the force of contraction, decrease in the rate of electrical impulse conduction. In large doses such as 50 to 100 mg, 1.5 mg per kg body weight given intravenously during general anesthesia. It is most popular antiarrhythmic agent used in medicine. Vasculature. Vasodilation is produced by direct relaxing effect on smooth muscles of vessel wall. In toxic dose, this action contributes to hypotension and cardiovascular collapse. Respiratory system. In small doses, it causes bronchodilation. In large doses, it causes respiratory arrest, that is apnea. The most common cause of death related to overdose of local anesthesia. The composition of local anesthetic solution with adrenaline. These are the components, their amount in 1:80,000 of concentration, and in solution with adrenaline 1:2 lakh of concentration. So the components are 2% lignocaine hydrochloride, adrenaline bitartrate, sodium bisulfite, sodium metabisulfite, methyl paraben, thymol, chlorbutyl, Ringer solution, sodium chloride, water for injection to make. Vasoconstrictor, its action are it decreases the rate of absorption of local anesthetic agents into cardiovascular system. It lowers the plasma level of local anesthesia and hence decrease the risk of systemic toxicity. It increases the duration and depth of action as higher volumes of ALA they remain in and around the nerve for longer time. It decreases bleeding at the site of injection. pH of LA with vasoconstrictor is more acidic, plain solution that will have less burning sensation and more rapid injection. Systemic actions on myocardium, it stimulates beta 1 receptor of myocardium. The cardiac output and heart rate are increased. Blood pressure, systolic blood pressure increase and diastolic blood pressure is decreased. On blood vessel, in small doses, beta 2 action predominates and vasodilatation occurs. In larger doses, vasoconstriction occurs because the stimulation of alpha receptors. Respiratory system, it has beta 2 effect on the smooth muscles of bronchioles. It is a potent dilator. It is a drug of choice in case of bronchospasm, as in bronchial asthma. Overdose, epinephrine reaction. The initial clinical features of epinephrine overdose, they are related to CNS stimulation, which include fear, anxiety, tension, restlessness, headache, tremor, weakness, pallor and palpitation. Larger doses which will lead to cardiac dysarrhythmias, dramatic increase in systolic and diastolic blood pressure, which may lead to cerebral hemorrhage. Now coming to the rebound phenomenon, epinephrine is frequently used as a vasoconstrictor for achieving hemostasis during surgical procedure. Its alpha effect predominates. The stimulation of alpha receptor that leads to vasoconstriction, resulting in hemostasis. However, subsequently the biotransformation, reuptake and redistribution finally results in low tissue levels of epinephrine. When beta receptors they are stimulated, beta 2 action predominates. The action on blood vessel changes, resulting in vasodilation. This rebound activity is manifested as some bleeding at the end of or a few hours after the surgical procedure. This is the dilution amount of vasoconstrictor. Maximum recommended dose of epinephrine in normal healthy adult patient 0.2 milligram per appointment, whereas in patients with clinically significant cardiovascular disease 0.04 milligram per appointment. Contraindication for the use of vasoconstrictor in local anesthetic solution. Patient with significant cardiovascular disease such as ischemic heart disease, hypertension and cerebral stroke. Patient with certain uncontrolled non-cardiovascular diseases such as thyrotoxicosis or hyperthyroid states and diabetes mellitus. Patients receiving non-specific beta blockers, monoamine oxidase inhibitors, tricyclic antidepressant and phenothiazines. Patients with sulfite sensitivity, patients who are undergoing general anesthesia with halogenated agents, and pregnant patients. Preservative. Modern local anesthetic solutions, they are stable and they often have shelf life of over 2 years. Their sterility is maintained by the inclusion of small amount of preservative such as capryl hydrocuprinotoxin. Some preservatives such as methyl paraben, they have been shown to allergic reaction in sensitized subjects. Fungicide. In past, some solutions they tended to become cloudy due to proliferation of minute fungi. In several modern solutions, a small amount of thymol is added to serve as fungicide and prevent this occurrence. Vehicle. The anesthetic agent and the additives above referred to they are dissolved in distilled water. This isotonic solution minimizes discomfort during injection. Local anesthesia armamentarium, syringe, needle, cartridge, topical anesthetic, gel, sprays, ointment, cotton swab, and applicator swab. Types of syringes, non-disposable and disposable. In non-disposable syringes, we have breech loading, cartridge type syringe. These are available in metallic or plastic. Aspiration or non-aspiration and self-aspirating could be side loading, pressure syringe, jet injector, Lurlock glass syringe, and in disposable or plastic syringe, we have safety syringes. So this is the first image of metallic non-aspiration syringe. The second picture, which is of aspiration metallic cartridge syringes. This is a special periodontal ligament injection syringe with ultra-fine needle, and this is intraligamentory pressure injection syringe. The syringe component, this is the thumb ring, this is the barrel of syringe, this is the piston rod, this is harpoon, and this is the threaded tip. And this is the needle, which is having bevel, shaft of the needle, hub of the needle, and syringe adapter, and cartridge penetration end. Needle. So the needle gauge, larger the gauge of the needle, smaller the diameter of the needle. Usual dental needle gauges are 25, 27, and 30. So these are the color coding system for needle gauge. The parts of cartridges are the cylindrical glass tube, rubber stopper, aluminum cap, and rubber diaphragm. Systems of local anesthesia cartridges. Local anesthesia cartridge color codes, newly mandated uniform system for local anesthetic cartridge bearing ADA seal of acceptance. So this is the local anesthesia with the concentration of epinephrine, and they are coded in color. Injection technique. The maxillary injection technique are supraperiosteal, PDL, intraseptal, intracrestal, intraosseous injection, posterior superior alveolar nerve block, middle superior alveolar nerve block, anterior superior alveolar nerve block, maxillary nerve block, greater palatine nerve block, and nasopalatine nerve block. So this is the supraperiosteal injection, which is given at the height of mucobuccal fold. Posterior superior alveolar nerve block. The direction of the needle is upward, inward, and backward, which is given above the second molar. Needle entry at the upper second molar. This is the anterior superior alveolar nerve block, also known as infraorbital nerve block. The first infraorbital notch is palpated, and which is given above the first premolar or the canine tooth. The needle entry at the apex of the canine tooth directed at a 45-degree angle. Then palatal anesthesia, greater palatine nerve block, and nasopalatine nerve block. In nasopalatine nerve block, the needle is penetrated just lateral to the incisive papilla. Then mandibular injection technique, inferior alveolar nerve block, buccal nerve block, mandibular nerve block techniques, Goget's technique and Vazirani-Akinosi closed mouth mandibular block, mental nerve block, and incisive nerve block. Inferior nerve block. First, we palpate the coronoid notch, then pterygomandibular raphe is identified, then intersection of the horizontal and vertical line. There we give inferior alveolar nerve block. Buccal nerve block, which is given distally to the most distal tooth in the arch. Then Goget's technique, which is given just below the mesiolingual cusp of the upper first molar, first or second molar, and is moved to a point just distal to the molar, maintaining the height established in the preceding step. So this is the insertion point for the Goget's mandibular nerve block. This is Vazirani-Akinosi nerve technique, which is given for in the direction first, second, and third molar, which is a closed mouth technique. This is mental nerve block and incisive nerve block. Technique and volume of LA solution. Inferior alveolar, the volume deposited is 1.5 ml. For buccal nerve block, 0.3 ml. For Goget's, it is 1.8 to 3 ml. Vazirani-Akinosi technique, 1.5 to 1.8 ml. Mental nerve block, the volume deposited is 0.6 ml. And for incisive nerve block, it is 0.6 to 0.9 ml. Coming to the complications of LA, local and systemic. In local, we have needle breakage, persistent anesthesia, facial nerve paralysis, trismus, soft tissue injury, hematoma, pain or burning on injection, infection, slowing of tissue, edema, post-anesthetic intraoral lesion, and in systemic complications, we have syncope, idiosyncrasies, toxicity, and anaphylaxis. Needle breakage. So care should be taken not to use short needle for the inferior alveolar nerve block in adults or larger children. Do not use 30 gauge needle for inferior alveolar nerve block in adults or children. Do not bend needles while inserting them into soft tissue. Do not insert a needle into soft tissue to its top unless it is absolutely essential for the success of injection. Observe for extra caution when inserting needles in younger children or in extremely phobic adult or child patient. Prolonged anesthesia or paresthesia. Most paresthesia they resolve within approximately 8 weeks to 2 months without treatment. Determine the degree or extent of paresthesia. We have to explain the patient that paresthesia is there, then record all the findings and examination after every 2 months. Facial nerve palsy. First, we have to reassure the patient. Contact lenses should be removed until muscular movement returns. An eye patch should be applied to the affected eye until muscle tone returns. Record the incident on the patient's chart. Although no contraindication is known to re-anesthetizing the patient to achieve mandibular anesthesia, it may be prudent to forego further dental care at this appointment. Then trismus, prescribe heat therapy, warm saline rinses, analgesic that is aspirin 325 mg is given. If necessary, muscle relaxants to manage the initial phase of muscle spasm. Diazepam approximately 10 mg twice a day. Initiate physiotherapy. Antibiotics should be added to the treatment regimen described and continued for 7 full days. Patient report movement improvement within 48 to 72 hours. Then soft tissue injury, analgesic, antibiotics, lukewarm saline rinses, and petroleum jelly is given. Cotton roll placed between lips and teeth secured with dental floss. It minimizes the risk of accidental mechanical trauma to anesthetized tissue. Hematoma, which is not always preventable, whenever a needle is inserted into tissue, the risk of inadvertent puncturing of blood vessel is present. When swelling becomes evident during or immediately after a local anesthetic injection, direct pressure should be applied to the site of bleeding. For most injections, the blood vessel is located between the surface of mucous membrane and the bone. Localized pressure should be applied for not less than 2 minutes. This effectively stops the bleeding. Ice may be applied to the region immediately on recognition of developing hematoma. Pain on injection. Other two proper techniques, both anatomic and physiological. Use sharp needles. Use topical anesthetic properly before injection. Use sterile local anesthetic solution. Inject local anesthetics slowly. Make certain that the temperature of the solution is correct. Buffered local anesthetics at a pH of approximately 7.4, they have been demonstrated to be more comfortable on the administration. Burning on injection. By buffering the local anesthetic solution to a pH of approximately 7.4 immediately before injection, it is possible to eliminate the burning sensation that some patients experience during injection of local anesthetic solution containing a vasopressor. Slowing the speed of injection also helps infection. Use sterile and disposable needle. Properly care for and handle needles. So now we'll see the edema. If edema occurs in any area where it compromises breathing, Treatment consists of the following. First position, if unconscious, the patient is placed supine. Then ABC, that is airway breathing and circulation. Basic life support is administered as needed. Definitive treatment, emergency medical services is summoned. Epinephrine is administered, that is 0.3 milligram, 0.3 ml of 1 is to 1000 concentration of epinephrine solution. Intramuscularly or intravenously every 5 minutes until respiratory distress resolve. Then histamine blocker is administered intramuscularly or intravenously. Corticosteroids is administered intravenously or intramuscularly. Preparation is made for cricothyrotomy if total airway obstruction appears to be developing. This is extremely rare, but this is the reason for summoning emergency medical services early. The patient's condition is thoroughly evaluated before his or her next appointment to determine the cause of reaction. Slowing of tissue. Usually no formal management is necessary for epithelial desquamation or sterile abscess. Be certain to reassure the patient of his fact. For pain, analgesics such as aspirin or other NSAIDs are given and a topically applied ointment, that is Ora base, is given. The course of sterile abscess may run 7 to 10 days. Post-anesthetic intraoral lesion. Primary management is symptomatic. No management is necessary if the pain is not severe. Topical anesthetic solution, example viscous lignocaine. A mixture of equal amount of diphenhydramine, that is Benadryl, and milk of magnesia rinsed in the mouth effectively coats the ulceration and provides relief from pain. Ora base, a protective paste with kenalog, can provide degree of pain relief. A tannic acid preparation, that is xylactane, can be applied topically to the lesion extraorally or intraorally. First, we have to dry the tissue and then apply. Now, the systemic toxicity. First, ventilate with 100% of oxygen, which will prevent acidosis and hypoxemia. Bag valve, mask, ventilate, and intubate. Initiate advanced cardiac life support, that is quality chest compression. Suppresses seizures with benzodiazepine and avoid propofol. Low dose of epinephrine is preferred, that is 10 to 100 microgram initially with titration. Avoid vasopressin if possible. If patient remains unstable, then infuse 20% lipid emulsion. Bolus 1.5 ml per kg over 1 minute. Consider repeat bolus. Initiate continuous infusion of lipid emulsion, that is 0.25 ml per kg per minute. If unstable, double infusion rate. Continue advanced cardiac life support. It minimizes acidosis and hypoxia and monitor arterial blood gases. If the patient remains unstable, continue above. Consider cardiopulmonary bypass. If the patient stabilizes, then infuse lipid for additional 10 minutes and monitor for recurrence. If anaphylaxis is there, assess airway breathing and circulation. Give intramuscular epinephrine, that is 0.01 milligram per kg, up to maximum of 0.5 milligram. Repeat every 5 to 20 minutes if needed. Call for emergency. Lie patient flat and raise patient's legs, also known as a trundle monk position. If breathing not impaired, then give oxygen and IV fluid. If no improvement, then IV epinephrine is given. But if in the oxygen IV fluid, the supportive therapy is given as inhaled beta 2 agonist for bronchospasm, antihistamines for cutaneous symptoms, vasopressors, and glucocorticoids they are given. Syncope. Treatment is immediately stop any dental treatment going on, loosen the tight clothing, place the patient in head low with legs elevated position, monitor pulse. If pulse is normal, sprinkle cold water, carry a gauze dipped in aromatic spirit of ammonia close to patient's nostril. If bradycardia is there, injection of atropine 6 milligram IV or injection mephentermine 10 to 30 milligram intramuscularly and give oxygen if necessary. Patients receiving anticoagulation or suffering from bleeding disorders, oral procedure must be done at the beginning of the day and must be performed early in the week, allowing delayed rebleeding episode, usually occurring after 24 to 48 hours, to be dealt with during the working weekdays. Local anesthetic containing vasoconstrictor should be administered by infiltration or by intraligamentary injection wherever practical. Regional nerve blocks should be avoided when possible. Local vasoconstriction may be encouraged by infiltrating a small amount of local anesthetic containing adrenaline close to the site of surgery. In pregnancy, lignocaine and vasoconstrictor, most common local anesthetic which is used in dentistry, extensively used in pregnancy, which are having no side effects. Esters which are better to be used. Accidental intravascular injection of lignocaine. They pass through placenta, but the concentration they are too low to harm fetus. Geriatric patients. When choosing an anesthetic, they are largely concerned with the effect of anesthetic agent upon the patient's cardiovascular and respiratory systems, increased tissue sensitivity to drugs acting on CNS, decreased hepatic size and blood flow may reduce hepatic metabolism of drugs. Hypertension is common and can reduce renal function. Same prevention procedures used with children. Liver disorders. Advanced liver diseases that include liver cirrhosis, that is jaundice, potential complications, that is impaired drug detoxification. Example sedative analgesic, general anesthesia, bleeding disorders, decreased clotting factors, excess fibrinolysis, impaired vitamin K absorption, transmission of viral hepatitis. The management is avoid local anesthesia which are metabolized in liver. There are amides, lignocaine, mepivacaine. Then esters should be used. Recent advancement. First is the introduction of articaine hydrochloride as an injectable local anesthetic. Second development is the formulation of lignocaine and prilocaine dental gel for topical anesthesia of periodontal pocket. The use of triazolam as an oral sedative or anesthetic is reviewed. The recent administration of triazolam in multiple doses have extended the availability of anxiety control to many dental patients. Dentipatch, lignocaine transoral delivery system, pre-injection 10 to 15 minutes prior to injection, root scaling or planing, apply 5 to 10 minutes prior to beginning of the procedure. Pressure syringe, they are used in intraligamentary injection technique, especially in mandibular teeth. The types are pistol grip and pen grip, and the second one is jet injectors. So this is the single tooth anesthesia or computer controlled local anesthetic delivery system, the VAN. We have to insert the needle either from mesial or distal into the gingival crevice. It makes a sound as PDL when it reaches the periodontal ligament. The advantages are it is a dynamic pressure sensing technology. It provides continuous real-time feedback when an injection is performed, resulting in a more predictable injection. It allows the PDL injection to be used as a predictable primary injection. Allows all traditional injection techniques to be performed. It also reduces stress to the patient as well as operator. The disadvantages, the cost and require additional armamentarium. Intraosseous injection. This is the alternative stabident system. Guide sleeve, they remain in hole in the bone, permitting easy access for needle. Drill the hole using gentle pecking motion and then insert the needle into guided sleeve and inject local anesthetic solution. Conscious sedation. The contents are definition, introduction, guideline for conscious sedation, difference between conscious sedation and general anesthesia, sedation technique, nitrous oxide sedation, drugs used for conscious sedation, and complications which are associated with moderate or deep sedation. Definition: a minimally depressed level consciousness that retains the patient's ability to independently and continuously maintain an airway and respond appropriately to physical stimulation or verbal command, and that is produced by a pharmacological or non-pharmacological method or combination thereof. So the difference between conscious sedation and general anesthesia. Conscious sedation at several visits the procedure may be performed, whereas in general anesthesia it is generally performed in a single sitting. In patient is cooperative but anxious and fearful, so conscious sedation is given, whereas general anesthesia is given when patient is uncooperative. Generally, no extensive investigators are required and no pre-medication is required in conscious sedation, whereas pre-medication which is required in general anesthesia. Patient is conscious and contact is maintained in conscious sedation. The airway is maintained and patient feels he is in control of the situation in conscious sedation. Whereas in general anesthesia, ventilation is required. It is a time-consuming procedure and patient cannot control the situation. The objectives is to reduce or eliminate anxiety, to reduce untoward movement and reaction to dental treatment, enhance communication and patient cooperation, raise the pain reaction threshold, increase tolerance for longer appointments, to aid in the treatment of the mentally or physically disabled or medically compromised patient, to reduce gagging, to potentiate the effect of sedatives. The indications are the patients who lack the psychological or emotional maturity, medical, physical, or cognitive disability, patients who are fearful, highly anxious, or obstreperous patient, a patient whose gag reflex interferes with dental care, a cooperative child undergoing a lengthy dental procedure, certain patients with special healthcare needs, a patient for whom profound anesthesia cannot be obtained. So these are minimal sedation, moderate sedation, deep sedation, and general anesthesia. These are the stages of conscious sedation: minimal, moderate, and deep. Responsiveness: the response is normal to verbal stimulation. Airway, spontaneous ventilation, and cardiovascular function, they are unaffected. Whereas in moderate sedation or analgesia, the responsiveness, purposeful response to verbal or tactile stimulation, no intervention is required, and spontaneous ventilation is adequate. Cardiovascular function, they are usually maintained. In deep sedation or analgesia, purposeful response followed repeated or painful stimulation. The airway intervention may be required, spontaneous ventilation may be inadequate, and cardiovascular function, they are usually maintained. In general anesthesia, no response even with painful stimulus. Airway intervention, they are often required. Spontaneous ventilation, they are frequently inadequate, and cardiovascular function may be impaired. The guidelines: health of a patient, ASA physical status, American Society of Anesthesiologists, ASA 1, that is normal healthy patient, ASA 2, they are mild systemic disease for well controlled and no functional limitation, ASA 3, severe systemic disease is controlled with no immediate danger but has some functional limitations, ASA 4, severe systemic disease that is a constant threat to life, poorly controlled or at the end stage, ASA 5, patient not expected to survive longer than 24 hours without surgical intervention, ASA 6, brain dead, maintenance for organ harvesting, ASA E, which means emergency operation of any variety. Certainly, dentists should only use sedation in the dental office for the patient that are ASA 1 or well-controlled ASA 2 patients. The recommended fasting guidelines for deep sedation or general anesthesia. These are the foods and the time prior to appointment. So the clear food 2 to 3 hours prior to the appointment. Breast milk 4 hours. Formula or non-human milk 6 hours. And the solids are then at 6 to 8 hours. Then types of anesthesia. The types are oral, oral route, inhalation, intramuscular, intravenous, and intranasal. The advantages of oral route: they are convenient, easy and inexpensive, whereas disadvantages are it cannot be titrate the drug. Higher doses and polypharmacy increases the risk. No oral reversible agent. Then inhalational route. The advantages are it is convenient, easy, rapid onset, they are odorless, well tolerated, and the disadvantages are it can cause nausea and vomiting. Then intramuscular route, it has more rapid onset, they are reliable route, potential for dose titration, and the reversible agents that can be used. The disadvantages are over-sedation possible, muscle pain from injection, difficult with needle-phobic patients, delay in onset of effect of reversal agents through the intramuscular route. Coming to the intravenous route, it is reliable, consistent, rapid onset, which have immediate effect, but the disadvantage is over-sedation possible and venipuncture difficult in needle-phobic patient. Intranasal route, more rapid onset than oral, potential for dose titration. It is reliable route. Disadvantages are over-sedation possible, may be unpleasant depending on volume, may cause burning sensation. No reversible agents are given through this route. Then nitrous oxide sedation. Thorough inspection or equipment. Place the mask over nose. Bag is filled with 100% oxygen and delivered to patient for 2 to 3 minutes. Then slowly introduce nitrous oxide. Encourage the patient to breathe through nose. Explain the sensation to be felt, that is floating, giving, tingling of digits. Adjust the concentration to 30% of nitrous oxide and 70% of oxygen. Carry out the procedure with continuous monitoring. After completion of procedure, give 100% of oxygen for 5 minutes. These are the drugs which are used, that are ketamine, intravenous or intramuscular, propofol, ketafol, etomidate, midazolam, and fentanyl. The complications are airway obstruction, anaphylaxis, aspiration, nausea and vomiting. These were the references. Thank you.